So my next topic is lenticonus, cataract surgery in lenticonus. That is posterior lenticonus. So what is posterior lenticonus? The lens is cone shaped in the posterior side. So it is definitely a congenital anomaly. So if we define it, it involves a bulging of posterior lens capsule and cortical matter into a cone shaped, which can progressively ossify, forming a cataract. The condition is unilateral in most cases and is often present in the childhood. So again, the chances of amblyopia increase in the childhood. So the lenticonus, the cases of lenticonus have a combination of pediatric cataract as well as posterior polar cataract. So both the cases are unique cases. The posterior polar cataract as well as pediatric cataract. So this becomes a very like a more important combination where we have to deal with the cases, such cases. So several theories has been proposed to the development of posterior lenticonus, which may include subepithelial capsular hyperplasia, embryologic hyalidatory traction, inherent weakness of the PC wall. So basically, what main surgical issue is with the PC weakening of the posterior capsule. This is what we have to deal. So a case of lenticonus may present in such form, either a plain lenticonus or there is a cataract formation in the posterior capsule or a lamellar formation, or there can be a complete cataract. So cataract associated with posterior lenticonus typically progress more rapidly than age-related cataracts and is usually seen in the pediatric cases, so it necessitates early surgical intervention. So what is the main challenge? Main challenge is the posterior capsule thinning. So there is already a pre-existing weakness. So what surgical strategies we can do? So first, preoperative evaluation has to be done properly. Now what we can do? We can see the integrity of the posterior capsule by ultrasound, or we can see with the OCT, anterior segment OCT, what is the status of the posterior capsule. So this can help in the intraoperative planning of such cases. So a precise, now coming to the capsular rhexis, since in the pediatric cataract the rhexis running off is the main issue, so we can use a more viscous viscoelastic. We can have controlled and precise anterior capsular rhexis by grasping, re-grasping and inward pull technique. Hydrodissection, hydrodelineation should be performed with extreme caution, again because of the weakness in the posterior capsule. A low flow, low energy phacoemulsification settings has to be used to minimize zonular and capsular stress. So these modification, intraoperative modification when we encounter such cases. Now the surgical management in case of total cataract in posterior lenticonus. Now usually when we approach, we go into the periphery, but in a total cataract there is a risk that there can be a central drop of the nucleus chunk or the liquefied material, since there is a liquefied material. So in some of the, we can just, this biscuit in chai, like when we dip, the center biscuit can drop inside. So that we have to deal. So we have to approach the central portion first, then we have to go to the periphery to avoid such conditions, such like incidents. There has been also described a pars plana lensectomy, vitrectomy and posterior chamber intraocular lens insertion into ciliary sulcus with central anterior capsulotomy. So a pars plana approach has been also been described for the lenticonus. So like IOL selection depend upon the posterior capsular status. Even a scleral fixated or a PCIL in sulcus with optic capture, this can be done for such patients. Then vitreous loss has to be managed more aggressively in such patients since they are young patients. So there will be a more vitreous loss. Again, the post-operative care should focus on the inflammation control, prevention of amblyopia in patient and monitoring visual axis opacification, which is more common in, as I have told, it is a combination of posterior polar and pediatric cataract. So both the strategies we have to combine to manage such cases. So with careful surgical planning and proper intraoperative modification, we can give a very good outcome and we can prevent amblyopia in pediatric cases. Thank you.
Thank you, Dr. Kanchan, for a wonderful presentation and such an informative